Thank you very much, Isabel. Since you introduced me so nicely, I would say that it's great to have the support that we have from BTA for this event, from James, who's been before. But you know, it wouldn't happen if I didn't call in favours from friends who happen to be, it's kind of like a busman's holiday, happen to be audiologists from Ireland or England or whatever. And I can just thank you very much for coming along, and not just themselves, but their partners as well, so who also are involved in the audiology world. And I guess we're just kind of become passionate about it. It's a great profession, industry to be in, where you can actually help people when whatever you're doing and make a living out of it as well. So, tinnitus variations and tailored treatments. I'll try and press the right button on the control this time. And what I wanted to talk about was some different ways to categorise tinnitus, major influences, and different symptoms. So there's different ways. There's been all kinds of ways we categorise it through, decades. So one simple way is objective tinnitus, and an objective tinnitus, an individual can hear the tinnitus, not surprising, but so can the clinician. So if they have the right equipment, they can hear it as well. So it could be a pulsatile tinnitus, so it's a blood flow, or it could be clicking of the jaw. But the most common type of tinnitus by far is subjective tinnitus. And the individual can definitely hear it, as many of you will know, but nobody else can. And in some ways that's the toughest, because why? What am I hearing? People have gone out and they went to the end of the street. You must hear that noise. Or is it the bin men coming at this time of the day? All kinds of really strange reactions to it, because it's so apparent to the individual, and of course it's oblivious to everybody else, which is by far the most common form. But another way of classifying tinnitus would be symptomatic and non-symptomatic. And in many ways I like that, and I think that would be the simplest way for first ports of call in the medical system to look at it. So your GP should, rather than go, well, I don't know, should think about, well, is it symptomatic? What's the problem? I can't get to sleep. So non-symptomatic is the easiest. Most people with tinnitus actually either have non-symptomatic tinnitus, or it's a very mild symptomatic tinnitus, because it's a noise. They say, they might talk to somebody, they might see the GP, and the GP will say, well, it sounds like tinnitus, any other issues or whatever, we'll send you to audiology, but I wouldn't worry about it. Of course, that ties in with what James said about what that first response is, whether you're reassured or whether they go, yeah, you're wasting my time. So most people with tinnitus, and it's maybe even distressing to most of you here, don't really care that much about it. It's a noise and they just get on with it. They might wish they didn't have it, but it's really just no big deal. But symptomatic tinnitus, that's why we've got people from Inverness here. We've got people that have travelled from other parts, quite far distances, because it really is a problem. It's something that has had a big impact in them, and it might have happened very soon, very, very recently, or it might have been there for 20 years, and they've just coped with it. But it's had impacts in their life out of all proportion to what most people perceive it should have. It's only a noise, but it stops people getting to sleep. I think there's a Geneva Convention against causing sleep deprivation with prisoners. When you have a problem with sleep, it's a big deal, and it totally turns your life upside down. So when somebody says that to the GP, you would think they would take it very seriously. Or maybe it's anxiety. Maybe they don't understand what's happened. And it's not just, it's a noise. They are feeling physiological things. Their tummy, they have butterflies in their stomach. Their hearts are racing. They don't know why this is so, awesomely impacting on them. They may even have that referral and had an MRI, and they've been told, there's nothing sinister there, pal, you're okay. But it still causes this anxiety. And of course, there's reasons why that's the case. It's not just in their head, it's a physiological response, and it's a reaction to that noise. And when you look at it, it's understandable why it happens, even if it's inappropriate, because your body is reacting inappropriately, but it's nonetheless absolutely real and powerful. It may cause depression. And again, one of the things I think that James touched on was this concept of, yeah, we won the lottery. Isn't that great? But this noise is driving me crazy. It really sucks your enthusiasm for life away. It just seems to take the fun out of life, and you're depressed. Now, I'm an audiologist. I'm not a medic. I'm not a psychologist. I'm not a mental health practitioner. I'm obviously aware of medical aspects, and I've done counselling courses and all these kind of things. But I can't diagnose these conditions, but I can recognize them because there's questionnaires that pop it up. And it's a question of then, can we tie that into a response to tinnitus, in which case perhaps our treatment will have an impact on that, or do they have to go to a medic, or do they have to go to a mental health professional? And sometimes it's both. So we work with people who are seeing a psychiatrist or a psychologist. They're attending ENT for things. But it doesn't have to be one or the other. So you've got to bear that in mind. And my job is to decide whether it's out with my scope of practice and I have to refer them to somebody because I don't have competence to deal with it. So it's about the degree. So sleep difficulties, anxiety and depression, I would call that symptoms of tinnitus. Very powerful symptoms of tinnitus. But of course, not everybody has all these symptoms. In fact, most people don't have all the symptoms. And that can be problematic as well, because when you get a group of people who are really bothered by tinnitus, you'll get one table over here saying, I sleep like a baby. It's not a problem. I don't know what you're going on about. And, best time, it's great, I escape my tinnitus. And there's another group who are saying, no, when I get busy at work, and that keeps me going, but as soon as I get home, I'm exhausted, and that's when it really pops into my head, and I just can't cope anymore. So it's understanding that everybody is different, and most people don't have all the symptoms, but some people do. But most people will have an individual mix. So to identify an appropriate response to treat them, we have to look at how that's impacting on them. And in recognizing very definitely that every single person with tinnitus is an individual. It's different to them because it's their sound. They can try and explain it to us, and that can be helpful. It's not terrible. Usually it's not that helpful clinically, but it's helpful for the person to be able to share it. And we sometimes go around the table in a support group, what's your tinnitus like, and try and get them to verbalize what it's like. And it can be funny once you start to share it, and you go, oh, mine's a bit like that. And you're sharing things, and that is powerful as well. So, one size does not fit all. One treatment is not going to have the same impact with everybody. It just won't. If we did have that, then we would have that protocol. We wouldn't have to have that map of the different ways that people have tried to help people with tinnitus, because there would be the answer. That's what we would do. So to treat effectively, we do need to tailor it to the individual. That's certainly my belief. We look at the most significant elements for that individual. And they might even vary over time, but certainly when they present, and that's one of the benefits of doing questionnaires, they help us diagnose, to verbalize, to direct what is the problem that that patient is really experiencing. Is it sleep? Is it sense of control? Is that the thing that they're missing? James has talked about how important that can be for people. But it's not that important for everybody. But for some people, it's crucial. Can they relax? They're fine. They work 23 hours a day or whatever, 16 hours a day. But when they get home and they go, I'll have my dinner and sit down, they can't relax. Their mind's going. And the tinnitus is keeping them, well, what do I need to do? I need to be busy. So relaxation is the thing that's missing in their life. Intrusiveness. Intrusiveness is really a massive thing. And in some studies, recently at Nottingham, intrusiveness was one of the big commonalities between talk therapy study groups and sound therapy study groups. How intrusive it is. I just can't drop it. It's there. It just pops into my head all the time. And for others, it's the concept of the impact on their hearing. These are not exhaustive. And by what I mean by that is they feel, whether it's right or not, that if only their tinnitus went away, they'd be able to hear properly. They would be able to cope in a noisy environment. So their impact in hearing has a big, massive aspect of it. That's their priority. And each patient will have a different mix. And for some, it might only be one. But for others, it might be, well, for some, everything's hitting the jackpot. Then it's very challenging. You've got to think, well, what is the number one bit that we're going to tackle first? But for most patients, there will be 2 or 3 or maybe 4 elements that are really sticking up above the parapet, and one in particular, or maybe 2 in particular, and then 2 other ones that might be close to that. And that tells us what our priorities should be. So is it tinnitus on its own with no obvious hearing loss? This is another thing. So most people, as I mentioned earlier, who have a hearing loss are not aware of it. You don't have to be going, every 2 minutes to have a hearing loss. It's very, very common, and you could say everybody over 18 will have some damage to their auditory system in the Western world. And it certainly isn't obvious for most people, and that's why most people with a clinical hearing loss take about 10 years to do something about it. Not just because they don't notice it, but because of other reasons like stigma, denial, all kinds of things, and almost as a grieving process that happens. But is it just tinnitus on its own? Is that the main issue? Or is it to a greater or lesser degree accompanied by hyperacusis? Now, hyperacusis you might know what that word means, and for some of you won't have came across it before. And hyperacusis is a strongly associated condition to tinnitus, and it's a sensitivity to sound. And it can imprison you in your own home because the world is just too noisy. And about 40% of tinnitus patients have an associated either hyperacusis, which has got a particular diagnostic criteria, or a lesser form of it, which we would call decreased sound tolerance. So it's not so bad, but it's still a problem, and it compounds the tinnitus. For a lot of people, I don't know what the statistics are, it's the hyperacusis which is the main problem, but tinnitus is a secondary problem. And I also mentioned just that hearing aspect. So about 90, there's definitely evidence that 90% of people with tinnitus have a non-standard audiogram. And I actually think that audiologists, we don't measure hearing very well. We don't measure the auditory system and I'll come into that in a minute. So with a combination, we have to prioritize. Is it the tinnitus that is the main thing? Is it hyperacusis? Is it hearing? And one of these or the other is the secondary or third issue. And that comes back to what are tailored treatments then? Well, very often it's not one thing or another. Why would it be? Sometimes it may just be one thing that's required, but very often it's not. Doesn't it make sense to look at the whole person in the round? To think about, well, rather than just deal with one thing, so we'll deal with how do you cope with your tinnitus better? Yes, I can cope better. I've got through that course of CBT or whatever. Now, these things are good, and they're clinically validated to show big improvements in the way people can get on with their life. So I'm not challenging their validity or their appropriateness. But it's about when and where and how they're explained to people. I was at a BTA conference in Dundee last week, and a very prominent CBT practitioner, Lawrence McKenna, said, well, no, I'm not really sure we should mix them, and maybe it's a good idea to think about sound therapy and so on first, and if that doesn't work, look at CBT or whatever. And that's interesting that, you know, such a prominent person takes that view, and it wasn't this is always the case, but it's an acknowledgement that there are more than one way, there's more than one way to treat things. But I still struggle with this idea that it's got to be one thing or another, because life's not usually black or white. It's usually shades of grey. And individuals are very much, you know, conflicted by, you know, different drives and ambitions and so on, and afflictions or whatever. And that's why I favour a holistic approach. And that, to me, my interpretation of that is treatment in the round. How do we deal with most of the bases? We have to prioritise things to try and get the optimum benefit. Because I almost feel we're challenged by science. I mean, we need to have evidence-based treatments. But my challenge to the scientific community is we need to look at real-world things. And things very seldom sit isolated, because humans are very complex. It's fine to do that with the guinea pig, and it's fine to do that with pill A and pill B, and we look at whether you grow hairs in your hand or your teeth fall out with pill A and pill B doesn't have any response. But when there's so many different drivers, I think it's a much, much more complex condition. I think that's one of the challenges. So if we know that 90% or more of people with tinnitus do have a hearing loss, and admittedly many people will have a mild anomaly, we might call it, rather than even a hearing loss, but some challenge to their auditory system, maybe we should look at dealing with that early intervention and encouraging that, because more and more research has shown that early intervention for hearing loss is beneficial for a multitude of aspects of human quality of life, about depression, about cognitive wellness, about dementia. And some of these things have commonalities with tinnitus. You know, feeling miserable, having, you know, these are, we do not have a direct link with this. This is the challenge, but we're getting definite causalities. And I think audiologists have got a lot to blame by saying, well, your hearing's okay. It doesn't stand out as a big problem. It's all right. And why is that? Well, do you know what? Part of it's cost. And that cost is cost to the Treasury, because, you know, health departments have a budget. It's cost to the individual if they go private, but it's also cost to their lifestyle. Oh no, do I have to wear bananas on my ears? And people go, oh, my granny had one of those. And there's all kinds of negative associations. So cost is certainly not pounds and pence. It's about how does it impact on your view of yourself And that's very important. I'm not old. I don't need to deal with my hearing yet. So one of the things that I think is essential, and I don't think it gets done often enough, even in tinnitus, inverted comma, clinics, is very detailed audiometry. Extended frequency audiometry. It should be done. The number of people who have come to me and said, well, I got tested and they told me my hearing was fine. And when you look at the whole spectrum, it's not their hearing, it's their auditory system, and it's very definitely damaged. And that's then no surprise that they're perceiving tinnitus. It's not, oh, I wonder what that is. There's an obvious cause and effect, and maybe even tie up with the frequency where there is that dip at 10K. And we're stuck in a time warp where hearing aids might only have been able to go up to 3 kilohertz, which is less than, is a fraction of the human auditory response. Never mind the hearing response about speech interpretation and so on. So now hearing instruments can go up into, 10 plus kilohertz response. And if we only test to 8 as a standard test, would you like to go and get blood tests but they don't do half of the results? No, you would kind of think, well, shouldn't you have done all the tests? And that's audiologists' fault. We shoot ourselves in the foot. We're such a, well, I don't think we're as a progressive profession as we should be. So detailed audiometry is important. And when we get questionnaires, now questionnaires are undoubtedly important. There's all kinds of reasons why they're not the ideal measurement, and we can't challenge that. But if somebody pulls a questionnaire and they're saying, I hate when they do a tannoy announcement in the train station, or when my granddaughter screams, or the puppies bark, well, maybe they've got some kind of sound intolerance, and maybe we, as audiologists, we should be investigating that. And there's actually protocols that say, well, we don't want to touch that in case we do things worse. So maybe we need to look at that. And you have to be appropriately trained, and you have to take appropriate measures and treat that person with extreme care and caution, and explain to them what you're planning to do. And they have to make an informed decision. But I don't think we do that. I think we do very blunt tests, and then we give them well, Douglas Beck talked about hidden hearing loss, and he said, all too often, audiologists give people the happy talk. There's nothing wrong with your hearing. You're absolutely fine. You need to pay attention when your wife's speaking. No, they can't hear. It's not in their mind. There's actually damage. They can't comprehend what's being said. The intelligibility is blurred. Don't just say concentrate. That's not going to do the trick. So we need to think of, can we correct the auditory system early? Now, there's various tests about causing a short-term hearing loss. That, kidding on, you've got a damaged auditory system. Pop an earplug in one ear and leave it in there for a week or two, and you'll get tinnitus. But good thing, it's temporary, and it's not actually damaging your auditory system. So take it out again, and your tinnitus goes away. Isn't that great news? But that's because it's not had time to template in the brain. The pathways haven't changed. There's not been any plastic changes in the brain. And if we did it for a year, do we really think it would go away? I doubt it. But it wouldn't be ethical to carry out the experiment. So we're not going to do it anytime soon. What I'm saying is early intervention for your hearing can make a big difference for tinnitus. The studies with Lyric, which is a 24/7 hearing system, you pop it in, and it's very often characterized as one of the most natural hearing aid interventions, because people who have got hearing aids then try that, and 90% of them will say, oh, it's the most natural hearing I had since my hearing went. But the real key thing for tinnitus is it's 24/7. And they don't have conclusive evidence yet, but there will be more longitudinal studies that I'm sure will show. In fact, there is evidence that it diminishes the impact of tinnitus, and it's probably because we're getting closer to taking that earplug out. The problem is most hearing aids are for physical damage, not an earplug, but damage in the ear or some other processing part of the brain. So, usually in the external auditory process rather than into the brain, although sometimes that can happen. But the point is, it starts mild and it snowballs. And quite often, but not always, so there's so many unanswered questions, tinnitus pops up. And if we could intervene with that tinnitus early, could we stop it becoming something that was more permanent? So very often children get tinnitus, and quite often they've suffered glue ear as well. So they've had what should be a temporary hearing loss, and they might also develop into hyperacusis. And if we intervened that with which would be an otherwise normal auditory system, we could perhaps stop that whole process happening. But the key probably is doing it sooner rather than later. So what else is important? Is just fixing your hearing loss the answer? Well, if we did it soon enough, maybe, and it's a big maybe, and I get that, but that evidence of experiments where you cause, well, let's look at this. Go into an anechoic chamber with no tinnitus, and you will almost certainly perceive tinnitus. Come out of that environment and your tinnitus goes away. I get occasional tinnitus. It's not templated. I don't get it constantly, or at least I'm not aware of it. So maybe if we could maintain your auditory system better and immediately, or we can't fix it, we can compensate, maybe that would have an impact on how bad or what prevalence tinnitus was. But auditory correction in most cases is not the only answer, because it's already templated, it's been there. By the time we actually intervene, the brain's probably adapted to it, and it's now trying to maintain that because it thinks that's the right way to carry on. So knowledge is power, and understanding what that mechanism is the next thing that's very, very important. A better understanding of what's happening, because when you understand it, you're not frightened about it. And you think, well, in a conscious level, this is something I shouldn't be worried about. So it's powerful. But most people are not Hoovers or even Dysons. We don't soak up that information and the penny drops just like that. Sometimes it's the clinician or the information. It's not, I'm using examples, but they're not clinical examples. They're ideas, and some people will get onto that and go, that makes sense, and other people just won't. So it takes time for the penny to drop for that individual, because it is such a complex condition. It's not just your ears, it's not just your auditory system, it's all kinds of other parts of the way our nervous system. It doesn't play ball, it does things that, I've not had tinnitus for a week. Why did it pop in for 2 days, just there? Now, you would think people would go, goodness, great, I've not had tinnitus for a week, so 2 days I can cope with. But very often it's, I know I've made progress, but it's not enough. And those 2 days, does that mean it's all going to go back downhill again? And we start having to shore progress up. So we know that for many people with significant tinnitus, hearing aids, including sound therapy, as either distraction or maybe manipulation, and education, aren't enough. But that's okay, because we know that there are other elements, and talk therapy and further empowerment can all play their part as well. So we know these things are valid too. I'm not dishing them. CBT and mindfulness have evidence-based results, and I'm not disputing that. And I'm not saying you shouldn't do that. In fact, there's no reason why you wouldn't do that, but some people will probably do better with perhaps relaxation. It depends on the study, and it depends on the person, because some people will adapt and decide, just as James said, yeah, this is for me, I can buy into this, and other people will go, no, I don't feel comfortable with that. So tinnitus counselling is very helpful, and So is think of it as an individual support group. When you've got that one-to-one and you can say, even just offloading, I have done really well, but I'm worried about it popping into my head, last Tuesday. Or when I go out and being able to talk through things is again very powerful. And I've certainly found that in my patients. So relaxation or mindfulness, I think, I've just put them here as the almost add-ons because I'm coming at this as an audiologist. But I'm definitely not saying they're the tail. In some cases, they are the answer. In my book, they're part of the picture. And I would look at that individual very definitely and give them options. So tailored treatment has to be tailored to the individual. We need to know what they need and what they want, whether they want more of something or less of something, and try and respond appropriately and give people information and listen to what they're saying, because it depends on how they respond. And one person will respond very well, and somebody else is just not making progress, and you have to take a different tact. Questionnaires are useful because they give us a measure of improvement. So one person's 7 will definitely not necessarily be the same as another person's 7. And yes, there's variation, and there's the concept of them wanting to please their person they're working with, all these things. But generally, if somebody starts off with a 10 and they go down to a 3, that's a good indication that they've made progress, rather than saying, and a good indication of the degree of progress, rather than saying, yeah, I feel a bit better. So we've got some way of categorizing it. But there are no magic wands. It does take time and resources. And that's a big element I want to get through to you. There are resources. That's why the BTA is looking for money from the government to do more research. We know that it needs more resources, both in money and manpower. Now, as a company, we are constantly investing in training. And we do. We go to, it's important. But so are staff. It's not a one-man band. It's important that we work as a team. And I'm delighted to announce, finishing my final presentation, that we've started 2 fresh and eager apprentices. This is Vera on your left and Luca on your right. And they are really keen. And like most people, when there's a team, they do ask important questions. You have to make your own decision about that. But I'm glad to have them on our team. And I've got a bit of music, but we're going to just keep that for the break, which was Elgar's Variations and Enigma, because I thought they were both appropriate to the whole concept of tinnitus. So we're not going to have that. Instead of that, I'm going to say thank you, and I'm going to make way for our next speaker.